To succeed in life, you need three things: wishbone, a backbone, and a funny bone. For our next session on spine, the current and future trends, I request our chairpersons to please come on the stage. Dr. Kapil Kulshresht sir is a very reputed orthopedic surgeon. Dr. Saurabh Anand Dubey is assistant professor in Department of Neurosurgery, MLN Medical College. And Dr. Sachin Yadav is associate professor in Department of Orthopedics, MLN Medical College. To speak on this topic, I welcome Dr. Rakesh Kumar Singh sir. Sir, please.
I think spine is the very common day-to-day problem in our practice of every clinician. And from our old days of student life, we only had few things for treatment like bed rest, analgesics, some braces, traction. And in surgery, I think only decompression, discectomy sometimes, and fixation. When I did my post-graduation, it was hard shell fixation, that's all. We have come a long way since then, and with the advent of the recent investigations and the high-tech investigations, MRI and everything, and treatment protocols and modalities, the outcomes have revolutionized, and we now can predict a very good outcome of treatment of any ailment of spine. And to know the present scenario and the future of our spine, we have Dr. Rakesh Singh. I will request Dr. Sachin to introduce him. Please.
Good evening, all the gentlemen. We have with us Dr. Rakesh Kumar Singh, Associate Professor Neurosurgery, Dr. Ram Manohar Lohia Institute of Medical Science, Lucknow. He has done various fellowship. Norman Kapner Spinal Fellowship from Exeter, UK, 2021-22. Spinal Deformity Fellow, Edinburgh, Scotland, 2020-21. Senior Clinical Spinal Fellow, Liverpool, UK. He has been course faculty in various courses, and to his credit, he has 43 publications in various indexed national and international journals. And till date, he has given 21 presentations. It's a privilege for us to have Dr. Rakesh Kumar Singh with us. He is going to give his presentation on spine, current and future. I welcome Dr. Rakesh Kumar Singh.
Missed one thing, I am the proud alumnus of this institution. Although my batch was very notorious, but I am belong to a very odd cohort, because being a neurosurgeon, I went to UK to train myself in orthopedic surgery, spine specialty, to complete my dual training for 3 years and then come back. So I have a lots of orthopedic colleague which is very close to me. So when Pankaj asked me to speak on spine, current and future, the only first question came in my mind was like, what is future in next 10 years for the spine surgery, especially in Indian perspective? So for declaration, I don't have any financial relationship with any company. So when I was thinking about the next 10 years, where we are going, or where we are, like what is the aim, as my anesthesia colleague already discussed about the pain, so we don't want as a spine surgeon, no pain. So that is the one aim. Second is, most important thing, all the research now are directed toward the preservation of motion of the spine. So we wanted to do minimum to gain maximum and preserve all the motion as much as possible. So this is one aim. As a deformity surgeon and the non-deformity surgeon also, I presented this topic in NSI this year. So even you are a non-deformity surgeon, so your aim should be balanced spine, which is going to improve the quality of life of the patient, which is your aim. If I see myself as a neurosurgeon and the spine surgeon, the difference is in the neurosurgery practice, we are dealing with, your action is basically divided into two, mortality or no mortality at most of the time. But as a spine surgeon, nobody is going to die if you are not operating someone lumbar spine. But definitely, the life, another the 10 or 15 years of life is going to be hell when you are not able to help him. So your job is to improve the quality of life, not other things. So don't give the morbidity to the patient. How we are going to achieve all these things in next 10 years? So we are heading towards the daycare procedure. Now I will admit my 80% of the patient with single level discectomy are daycare. Minimal invasive endoscopic, sir is the founder of, like, I will say the pioneer of the endoscopic surgery here. Awake spine surgery. Definitely it is not the single person game, it's a team event, and basically we are dependent on our anesthesia colleague on this part, but definitely some tools and techniques. If you want to do anything for betterment for the future, you need a good tools and technique. Without robotics, I can't say we are going to the next 10 years. I'm expecting this in next 1 year. So augmented reality, yes, it is very useful. And I will show the interesting cases, and we are heading toward the future of fusionless spine surgery. And especially we are talking about all these three things, but we are forgetting about the type 2 prevention. So a stem cell is coming in that role. So what next? If I will try to inculcate in a 1 or 2 pictures, so this was our spine surgery past with a very basic outside of the aircraft, and this cockpit, which is very, very, very basic, which is indicative of your tools and technique. So you need to be very, very fine to improve, like you should be sure. So you need your precision, fine accuracy. So how we are going to achieve this? This is our current picture. We are flying very high in a good sky, but as a spine surgeon, I'm not satisfied at this level. I want my speed to be supersonic with 101% accuracy, precision, and with lots of technology, navigation. Even I wanted a patient which I am going to operate to anticipate what he or she is going to be, which direction he or she is going to be in next 5 to 10 years. So that if he is going in the wrong direction, I will anticipate now and I will do something to prevent, to help the patient. So definitely safety and recovery is going to improve and ultimately resulting in the good quality of life. So I am firm believer that there is no healthy life without a healthy spine. So I'm going to discuss lots of questions, lots of clinical pictures and the surgical perspective of this in the Indian practice system. So my first case, it is from my Edinburgh fellowship time. So this girl came to us. She was continuous 5 years ballet national champion of Scottish, and she came to us with this like a small curve. We'll say the deformity is less than 40 is a small curve. So she was on the waiting list for 4 to 6 months. But suddenly one day, her mother called and said, Mr. Singh, actually my daughter is getting breathless in the practice of ballet. I was surprised because with this curve, so I asked for the X-ray. Repeat X-ray. If you are able to see this here. So this is fine. It's approximately 37 degree of curve. But look at here. Even the small curve, but lung comprise is almost gone. So that was the reason we called next day plan surgery and created this and helped this girl to getting a respiratory improvement on the next same day. So it is not a cosmetic surgery. So we have to be vigilant. We have to be very clinical judgment taken for the surgical perspective, even being the small angle of the patient. So next, this is the next last month operated patient. So her deformity is known to her family as usual in the Indian context for next 7 years. She was appearing in the 12th examination. She was not able to sit for more than 4 to 5 hours. So that's why she came to us. So after discussion, we planned surgery, and if you will able to appreciate the lumbar curve is very rotated, and that's why this patient, I know that patient is not going to even ably sit properly for 30 minutes because axial pain is the main complaint here. We corrected it, and now within 1 month, she is able to sit 4 to 5 hours and preparing for need and inspired for the spine surgeon. So this is the patient we got last month from Patna, a referred patient. I just wanted to give you a perspective for our general practitioner here. If you will see any kind of congenital problem in the baby, believe me, it is not a single problem. It is a bunch of combined problem. So always and always, as a general practitioner, try to evaluate patient for other things. This patient was for me with this problem and like big bump and big kyphosis. But with history, there was a history of VSD repair, there was a history of anorectal repair, so I was damn sure with one interaction, this is a syndromic patient, most probably vectoral, and it was. So I diagnosed the bilateral hydronephrosis, which was taken care by the urologist. I operated this, corrected well, but again, he is about to discharge, and this is the clinical picture. You will be able to appreciate this is on positioning, this bump is here, and with the 6.5 centimeter height gain, absolutely fine. So with these three index pediatric picture, where we are going to head? So now the next level for us as a deformity is to gain this fusion-less surgery. So what we have, so VVT is coming up. I have borrowed this slide from one of the my very good friend who is a pioneer in VVT from Germany. So it's an 8-year follow-up, and this is almost we have able to stop or some degree of correction with a good balanced spine, but there is no fusion. So that is the future. Next, if you are in the general practice, either be a specialist or non-specialist, definitely you are going to get this population with the backache and this. So what new or what thing was and what is and what we are expecting? So for me, there is no laminectomy. I have not done any single laminectomy for last 4 and 5 years approximately for degen problem. But honestly, all the patients are much better, doing very good in quality of life. So you can do without laminectomy. There's no need for laminectomy. So open microscopic, we are here at MIS endosurgery, and still I will say we are in the phase of development of the techniques and technology to help. And in 5 years, we are expecting too much of things, which is incorporated like AI incorporation with the MIS endo techniques. So of course, this part is mainly belong to the anesthesia person. So currently we are heading towards awake, but trying to go for the daycare local surgery. Second thing is daycare surgery is yes, it is the future for most of the spinal procedures, including 1 or 2 level of fusion. But what is the main goal? Main goal is to return to work early. Definitely, we are a quality improvement surgeon of the life, so we can improve the quality of life to be giving return back to life early as much as possible. So what we are going to do very focused, very accurate, adequately needed what is need. We are not going to do anything like previously do 2 or 3 level of laminectomy for one level disc. So anticipation of the future problem is main. And there are a few tools. If you inculcate that tools in your practice, you can really anticipate where the spine is going in the next 5 to 10 years, and then you can do something to hold or prolong that problem. So always do minimal invasive, which is required. So here, laminectomy, yes or no? I am no. So laminectomy, look at this. All the posterior band of a spine is very important for balancing, for degeneration, progression, everything. Don't take like an appendix. So it is not a vestigial organ, so try to preserve it. This patient, I will show you next slide how we have managed. This was managed last month. So for excluded, even the migrated disc, upper migrated, we do only fragmented with the MIS technique and post-op day 1 discharge. So this patient was managed by MIS TLIF, less than 50 ml of blood loss, discharge on post-date 1, no brace, return to work in 1 week. And this is the MIS TLIF case, well-placed case, and pedicle screw percutaneous. And this much amount of disc is excreted. Next. So this is the problem which is very common. We always talk about in the general conferences, general practitioners, the degenerative problem. But as a spine surgeon, and where we are heading, I will include in these 3 slides. So problem is 1, but for me solution for different patient is 3 different. So I can, few patient, I will do the approach for posterior, which is from back. Few patient is most suitable. I know they are most suitable for lateral approaches, and few patient I will go blindly for anterior approaches. So that is like one slide I have tried to incorporate all these things. So T-leaf, O-leaf, or X-leaf, and A-leaf. I will give the example of next one. So this is the example for open and MIS T-leaf. Open T-leaf, you compare with the MIS T-leaf, approximately 250 or 300 of blood loss in open as compared to less than 50. Discharge day is usually 2 to 4 day, post-operative day for open. This is 1 day. Even we are trying to get less than 1 day for discharge of the patient. To return to work is very significant because it's in months and it is in weeks. So you are improving the quality of life by your action. So MIS OLIF is the oblique lateral interbody fusion, sorry. You can appreciate the slip here with the extension, so dynamic foraminal stenosis picture with claudication. So in this kind of picture, I will try to incorporate a big cage, try to create a disc as much here to prevent the adjacent level degeneration for future prevention, which we are talking. So my preference will be lateral approach, do MIS, send it next day home, and return to work as early as possible. So same here. So in this picture, if you're able to appreciate main of, like in the nutshell, all the movement, like most of the movement and lumbar lordosis is below, so 4 and below. So in this patient, if I will see this picture, I will definitely try to incorporate all these things, like create a lumbar lordosis, good lordosis here to prevent further degeneration up and down. So it's like anticipation of problem, doing something MIS, return to back early. This is the future where we are heading. So if you will see this picture, I will say in our spine terminology, it is flat disc at this level. And this is a pseudo disc causing the bilateral foraminal stenosis. Patient definitely is present with the neurogenic claudication. And it is very common in our Indian context with elderly people. It is very, very common. So, and they will appreciate foraminal stenosis and this almost flat disc. So what is preference for us? So if you will try to do anything, is my preference for these patients will be do very minimal one, like just like ACDF, 1 and 1.5 surgery, go anterior, do A-lift, and just alone A-lift, next day home, and everything is fine. Claudication is went off because you have done the indirect decompression for the patient. You don't need to take off the bone from back and do some like muscle evaluation, everything. No, nothing. So in this patient, it's the same procedure, but look at this. If you have an idea about anticipating like type of pelvis, this is a type 4 pelvis. So everything is bound to slip. If I will see this patient in early age, I will inform her, look, you are bound to slip, you are bound to listhesis, there is most probably you will find out some kind of pars lengthening or ischemic thing. So I can say, look, if you have a problem, come early. I will do something for you, I will help you. If this is the condition, definitely she needs anterior and posterior support. So I will do this A-lift. This is the dynamic lumbar canal stenosis. Look at this here. So in the flexion, it is opening, and extension, it is closing. So my preference will be, again, do some lateral lift and do indirect decompression. What about the adult degeneration spinal deformity? This is a very common picture. Adult degeneration deformity, especially in the Indian context, this is very, very important to understand what was the, what level of impairment is this problem is giving to her. She was government servant, 55-year-old, severe claudication, otherwise healthy. So I helped her with this, doing 2-level with this much of incision, lateral incision, 2-level O-lift, and MIS correction. And next day discharge, 4-week return to work. So this is the future. So again, this is the iatrogenic spinal deformity with the implant failure. Look at here. It is iatrogenic because you have created, you have stopped the movement here, so there will be proximal junction problem with failure of implant. It is bound to fail. I will say it is bound to fail. So correction is this. So we have to go pelvis and 1 level up. So again, we are doing the cervical IDM with the MIS technique without doing laminotomy, and return to work with 2.5 centimeter of incision. Fracture, same here, is L2, burst fracture. Then we are trying to preserve as much as possible movement here with good construct. So doing MIS lateral corpectomy and doing 1-level fusion with adequate decompression and stabilization. It is going to be perfect with anticipation of the problem to prolong degeneration level below. So this is my technique. So it's a pre-operative planning. You can anticipate, you can, like you have planned for 1, 2, 3 techniques. You can inculcate all these 3 and you can see where your spine is going for after the surgery. And then if you see this is the main problem, we can do something before that. Second thing is, of course, implant. There are lots of improvement with the implant, including this nanotechnique, fusion technique, and pedicle screw. This is the usual picture. This is the last, it's planned for the next month. It's the one implant failure. Neuromonitoring is must for all the complex patients. I do all the like SCP, EMG, and MEP, and after correction or after doing all these things, final should be there, and it will be documented. It should be documented, there's no question. So neuronavigation is also very helpful. We did, in 2018, we did C1, C2 navigation screw. Thoracic and lumbar spine, especially in the deformity, is not the routine for the deformity correction, but definitely in some complex cases, we want this. Robotics is the future, so this is training for robotics. Most probably in coming year, we are expecting this arm with us. So now here, especially if I am not mentioning the augmented reality, in the minimal invasive technique, we'll incorporating with the extended reality, it will be not honest discussion with the future. So what is next? Next generation, if you're using the goggles, the eyesight allow you to see all these things, 3D model when you are operating. So this is the picture. If you are operating from here, I'm assisting you from US, I will say, I will use the WebXR, and then I will augment my thing with replication with your hands, so I can do this. Again, the frameless thing for my glasses, I don't need to bear the glasses. I just like a lens, I will bear, and I will see everything in my eyes, and I can operate without anything. So this is the picture. This is the one slide which we have to mention for prevention. We are coming with the lots and lots of stem cell things for the regeneration or the prevention of degeneration and low back problems. So we're here. So now, with all the discussion where we are heading, so if I will have to explain the future, then I will say I'm happy here, but I am not satisfied. So what is my future? So my future is this. I want to work like an astronaut with the more than 100% accuracy, precision, to improve my quality of life of the patient with all these tools. Thank you very much for the time. I appreciate it.
Thank you, Dr. Rakesh, for excellent and very entertaining presentation. Any question from the house? If not, I have one question.
Sir, please.
In all your cases, you have fixed the spine even after discectomy. What is the indication? What you follow?
No.
Do you?
First of all, I will correct your first question. So I have not fixed all the spine. I have shown the technique here. Okay. My fixation level.
What is the criteria then?
Yes, that's I'm coming. So my fixation threshold for a spine is very, very high. Until unless there is instability, I'm not going to fix it. Even then, let explain you, grade 1 listhesis, which is very common. I never fix it. So until unless there is instability, or I am predicting something which is going to be after you do the recurrent disc was there. In recurrent disc, I have a very low threshold for fusion because I have a very bad experience during my fellowship. I have operated, in UK, you can't operate. You can't operate patient in fixation without consent of 60% of surgeon. So we did 3 times. In one patient, we operated 3 times. He presented all the times with cauda equina and ultimately landed up into T-leaf in a 1 year time. So in recurrent disc-like condition, I have a very low threshold for fusion. Otherwise, I have very high threshold for instrumentation.
Thank you. And any other question?
Dr. Rakesh, there is a question from my side.
Yes, Sachin.
If there is concomitant facet joint arthropathy along with disc prolapse, does it changes your modality of treatment?
No. This is very common problem in the elder population. So definitely, that's why I'm telling you, you don't need to take out laminectomy. It's the interlaminar space you can utilize. You can preserve the facet what is there, and you can do your job just like decompression.
And when do you replace the disc?
Honestly, lumbar spine, I have seen 3-4 patients. Actually, this lumbar spine 5-6 or 4-5 replacement is very common nowadays in Europe, especially in Germany. And most of the time, I will say, there is axial pain is present even after surgery, and there is a good chances, even 50% chances for, again, complication, especially vascular, so we don't do lumbar spine replacement. We are proponent for the cervical spine, but ultimately in 4 or 5 years, it is going to fuse. So I say very honestly to my patient, look, I can help you with disc replacement, showing some movement for 3-4 years, but definitely you are also going to be same fusion as some ACDF patient. So you have to accept this.
Thank you, Dr. Rakesh, for your excellent
Thanks a lot.
presentation. Thank you.